Alright, so my name is Jose, and I'm going to be the moderator for today. Let me tell you a little bit about...
I would like to welcome everyone to our operating room here at St. Barnabas. Let me just quickly kind of set the stage to what you're seeing. Right now you are looking into operating room number 1, where we just a few moments ago started the donor service. You can see that we've placed our laparoscopic ports here. And I'll explain a little bit more about that in a minute. Let me explain who I have in the operating room. To my left is Erin. Erin is physician assistant. She's acting as my first assistant in surgery today. To my right is Jackie. We really should be on the other side of the table, but somehow it's on this side of the table. But we'll discuss that with Jackie after the case. But she is our scrub nurse and will be handing us instruments on the sterile field that we're going to be needing while we are operating. And above the curtain is Dr. Calamine, who is providing anesthesia. And Jose, today we'll do a little different. We'll do the anesthesia in room number 2. Because Dr. Calamine is extremely camera shy and he actually has laryngitis and can't speak right now. So we'll do the anesthesia part in room 2. Also in the room we have Meredith and Sewell, who are off camera. And they are our circulating nurses. And what the circulating nurse does is if we need anything field, they can get those for us and onto our field. You can see that we started a few minutes ago. We have 4 ports in the abdomen that we're going to be using.
One up here that has the camera that Erin will be holding. 2 over here that I will be using as my primary operating port. And then this 3rd port back here that's kind of a port for retraction that Erin will be kidney in certain positions. So that I can operate with these other 2 ports here. And about our patients and what today. You are looking now at exactly what I am looking at, and that is this patient's left kidney. This patient is JR. She is a 62-year-old female who is serving as a kidney donor. For lack of a better explanation, it's essentially her in-laws. I guess it's her daughter's mother, so they're in-laws, and our recipient is a 62-year-old female who suffers from kidney disease due to which is a systemic disease that can affect a couple of different organs in the body, but typically affects the kidneys and can cause kidney failure. And she has been on dialysis for a few months now. We'll talk a little bit more about the workup for our donors and recipients and who can be a donor in just a minute. We did a little preliminary dissection, namely we moved the colon and the spleen to cover the left kidney. So we mobilized those structures so that we're looking only at our left kidney now. And you can see here is the upper pole of the kidney. So our patient is essentially lying on their right side to have the left flank kind of up in the air exposed. So this would be the upper pole of the kidney toward the head of the patient. This would be the lower pole of the kidney toward the foot of the patient. This is essentially the back of the patient, and this is really towards the middle or the midline of the patient. Okay. There are 3 structures that we're going to be dissecting out in order to remove the kidney safely and in order to be able to transplant the kidney. And one of those you can see here, this is the renal vein. That's the vessel that brings blood away from the kidney and returns it toward what's called the vena cava and ultimately to the heart. So that's the renal vein. There is a renal artery that we have not yet seen, but I have a pretty good idea where that is. And there is over here, we can see where you are, we can see the ureter. The ureter is a little tube that carries the urine from the kidney to the bladder. We're going to look at that a little bit more later. Let's proceed with our dissection now. Can I have the harmonic scalpel, please? Now, there are some branches on my renal vein that I don't actually need, so we're going to be dividing some of those. And the way we do that is we're going to free them up. This instrument is called a harmonic scalpel, and you can see it has 2 blades that are slightly different. The blade on the bottom vibrates at a very, very fast frequency. The blade on the top just kind of stabilizes the tissue. And what it does is it forms a very localized heat reaction and enables us to divide tissue in very small blood vessels without bleeding. There's a little branch right there. However, this will not seal larger blood vessels, so we need to do something else. This is a vein branch right here. And I have
a Maryland for a second. And what you're seeing in there now is actually, it looks like smoke because it is essentially smoke. Tissues in the body have a very large percentage of water, and when we apply a localized heat to those tissues, that water essentially gets vapor, essentially steam, and what looks like smoke or steam. Okay, can I have a right angle clip applier? So this is a clip that we use to seal some of the larger or medium-sized blood vessels. And we have to seal these on two sides. We seal them on the kidney side, because I don't want it to bleed on the kidney one. But more importantly, we seal this on the patient side. Why? Because I don't want any bleeding. And these are made of titanium. They're completely non-reactive. They won't cause the patient to get caught in an airport metal detector, and they won't cause any problems for the patient. So there's one branch. Let's look at the renal branch. Now you can interject at any time, Marilyn, again, please, to ask questions.
When a patient presented to a dentist with a tumor on his jaw, this dentist found a doctor in Boston who administered ether by mask, soaked a sponge, a gauze sponge, and let the patient breathe in the vapors. The patient became unconscious. The surgeon cut the tumor out of his jaw. Shortly after that, the patient woke up. He lived, he had no memory, he had no pain, he had no awareness. And that was 1846, and that heralded the beginning of the modern day field of anesthesia. We've made tremendous advances in those last 160 years. It's very safe, and we're able to provide a wide range of services for people undergoing as minor procedures as a colonoscopy to as major procedures as open heart operations and heart transplants. What hasn't changed is that there's several basic components for a modern day anesthetic. The first one of those is that there is amnesia, in the sense that the patient will have no recollection, no memory of the events during the surgery, and that's very important. The second is called anxiolysis, which is the prevention of anxiety or fear that could occur around the time or during the procedure. The third component of anesthesia is analgesia, meaning the lack of pain sensation. So all anesthetics interrupt the sensation of pain traveling from the periphery up to the brain, so that there is no perception of any uncomfortable stimulus. And the fourth component is that the patient doesn't move. There's some degree of muscle relaxation. We accomplish that through a variety of drugs, both inhaled and injected, so that we can provide the patient with a safe atmosphere under which to go to surgery, and also provide the surgeon with the conditions he requires to successfully complete the operation. So my job is to really have some understanding of what the surgeon is doing, what his procedure entails. I have to interview and carefully discuss with the patient their history, so that I understand what they're going through, and then I have to come up with a plan so that it's safe for the patient and safe for the surgeon, and guides the patient through this difficult time while they're having surgery, and has them wake up at the end pain-free, without any confusion or memory problems, and no awareness of what happened. What I have behind me is my anesthesia machine, which you pan back a little bit, we can see the whole thing. We'll talk about all the different components. What's important right now is I have my monitor up here, which gives me my vital signs, and I'm looking at both the heart rate. As we move down here, I'm looking at something called, this red squiggly line to you, is the central venous pressure. Prior to the surgery, we placed a special intravenous line into the neck of the patient, into a large blood vessel above the heart, so that I could measure this.